I just want to remind the audience that we have scheduled it so that at the conclusion of the fourth panel this afternoon, we will have a period of time for open discussion in which we anticipate that members of the audience will not only raise questions for any of the panelists, but also make suggestions for the future of the movement in quality and patient safety. So please, recognizing that we've got relatively little time for the questions at the moment, be sure that you're primed for the session prior to our adjournment. While they're taking seats, I would call your attention to a very interesting approach to safety in relation to reporting called the Good Catch program. There's a number of institutions. The one that I'm most familiar with is MD Anderson, in which the ward teams were organized as baseball teams. They had their own hats and so forth, and you could report on the computer either by name or anonymously a good catch, which was a near miss as well as a real error. And setting up that program allowed hundreds, in fact close to 1,000 good catches within the first 9 months of the program. But there was a system where there were responses to each catch, and something was done about it. My favorite example is that of a nurse who was taking a patient to the operating room and noticed that the IV bag had heparin in it. He not only took down the bag and threw it away, but he notified the pharmacy of what was happening, and there was a systems error in the pharmacy that allowed overlap of IV bags. That's the kind of good catch that can start in a variety of ways. This panelist was organized and chaired by Dr. Carolyn Clancy, who's the Chief Medical Officer for the Veterans Administration, and she will introduce the panel and the discussants. Thank you.
Thank you, Ken. Good morning, everyone. I do have to say something about the Good Catch program. At our New Orleans facility, they not only have a Good Catch program, they actually have a newsletter that goes out electronically called Crawfish Tales to try to encourage people and to celebrate how wonderful it is to have good catches. So we have a terrific panel assembled here. I'm going to make some opening comments. Each of them, and introduce them. Each of them will speak for a very short period of time. Then I'm going to get to ask them questions, and you are too. So our topic today is policy impacts on patient safety. But before getting into that, I wanted to just make a few framing comments. First is to thank the committee and the Institute of Medicine, National Academy of Medicine for the phenomenal work. This is a town, I'm sure you'll learn, Dr. Zhao, and have learned very clearly, that has a lot of reports. In fact, I was testifying about a year ago with our secretary, and I referred to the Joint Commission, and one of the senators got very impatient and said, commissions in this town are a dime a dozen. I explained to him later who the Joint Commission was. But if you think about that as the target audience and what huge impact to errors human and crossing the quality chasm had, it is really a breathtaking achievement. I believe the only report from this distinguished organization that was announced from the Rose Garden. So something to be told. The truth is that first do no harm is a bedrock principle of medical care. And I think it's fair to say that in response to that report, we have seen many, many organizations across the country and literally around the world step up to this challenge. And we've also clearly made progress in selected areas, and yet everyone, from Leapfrog to medical professional organizations to fill in the blank, agrees that we have not. The National Patient Safety Foundation, which has just released a terrific report at 15 years, agrees that we have not reached a place where healthcare is consistently safe, or not yet. Policymakers have not been shy here. And if you think about it, governments, state and local and federal, have a lot of levers at their disposal. They pay for care. In some cases, they provide it, as in the Veterans Health Administration. They buy a lot of care. The federal government in particular supports research, training, regulation, and sometimes that's done in a delegated way through accreditation organizations and so forth. So a huge amount of potential actions that they can take, and many that they have taken. Now, historically, the medical profession in particular has been delegated to, we've delegated a lot of regulation and oversight to private sector organizations. So that makes this mix very, very interesting, and I'll certainly say at the early days of ARC under John Eisenberg, we recognized that it was enormously important to get input from those same clinicians. And what was really remarkable was they had to have their own stakeholder listening session because so many organizations wanted to step up and say what they thought the most important areas for further research was, and they were limited to 3 minutes, and this took like 2 full days. People were completely exhausted. We have seen multiple states as well as CMS require some kind of reporting on adverse events or avoidable harms. Now, there's a lot of definitional issues here. Not all falls are equivalent. Sometimes the result of a fall is a life-threatening event, and sometimes it means somebody slipped off the chair. For the people who have to do the reporting, this is not such an easy thing to work through. And by the way, states have different definitions. Sometimes that reporting is voluntary, sometimes it's mandatory. A lot of discussion about should near misses be part of this or not. Health IT, of course, starting about 10 years ago, was seen as part of the solution, our pathway to heaven and getting there thinner as well. And then, subsequently, within a few years, became seen or perceived to be not only a potential solution, but also a potential source of errors, and most definitely a target of multiple policies. The training of health professionals was first initiated in a very big way in a policy framework by New York State in response to the death of a young woman named Libby Zion, whose parents were very, very strong and effective advocates, and they ended up regulating working hours as well as the level of supervision for trainees. And subsequently, the Accreditation Council on Graduate Medical Education adopted that, and no surprise, another Institute of Medicine report. A huge amount of work recently in the payment arena, really initiated by Leapfrog, I see Leah here, but subsequently picked up by CMS and other private sector payers, non-payment for never events, reimbursement linked with clear policy goals such as reducing readmissions, healthcare acquired conditions, or avoidable harms. And of course, there's been regulation as well, including the creation of the passing of the Patient Safety and Quality Improvement Act, which gave the Agency for Healthcare Research and Quality, or AHRQ, a very prominent role in certifying and establishing patient safety organizations with protections for reporting. Some states, like Massachusetts, had requirements that all hospitals have patient and family advisory councils, collection of information on unsafe drugs, devices, and so forth, and a huge amount of work on research, which was both project-specific and ranged in the early days at AHRQ from focusing on sort of the basic science of safety to training for researchers, as well as training for people who worked at a state level in how to deal with reports and so forth, to the development and deployment of very practical tools. And most recently from the Institute of Medicine, a new report on diagnostic errors or improving diagnosis. As someone very, very proud to have served on that committee, the definition thrills me. It is the failure to provide an accurate explanation of the patient's problems or to communicate that to the patient and family. Think about that, because communication is a huge, huge part of this. So this says, is there a role for policy in patient safety? Oh, yes. And the question is, given that we've made progress, but we still have so much many opportunities ahead, what is the role for policy now? So I can't think of a better panel than the people assembled before me. Now, I just want you to know that if I were to read their bios, we would be done at 12:15, and I'm not going to do that. So suffice it to say, they are all very, very accomplished individuals, so I will be very, very brief. And then, unlike the program, I'm just going to be arbitrary, and they will make their initial presentations in alphabetical order. So, 2 people away from me is Judy Ann Bigby, currently a senior fellow at Mathematical Policy Research. She is a medical doctor with more than 25 years' experience as a primary care doctor in health policy, served as health commissioner in the first administration of Governor Deval Patrick in Massachusetts. Again, much more to her story, but I'm going to move on. Patrick Conway is someone I worked quite closely with at HHS. Even reading his titles would eat up too much valuable time. Let me just say, for all clinical issues at CMS, this is the person. It all goes to Patrick, and he does have 3 or 4 different titles. I think the most remarkable thing about Patrick is that every place he's ever presented, that I've ever run into people, they always say, wow, what a breath of fresh air, a whole new approach to how we can work together. Continuing down the alphabet, and on the other side, Judy's other side, her left, is Dr. Rick Kroenig, who became the new director of ARC in August of 2013. Prior to that, he had been serving as the Deputy Assistant Secretary for Planning and Evaluation, overseeing the Office of Health Policy, did a huge amount of research in that position, and prior to that has done some very, very important policy and research work at a state level, and was recognized by the Robert Wood Johnson Foundation some years ago as one of their senior investigators in health policy. This is an award that people covet and die to get. And then last but by no means least is Margaret, although as we know her as Peggy O'Kane, is the founding and current president of the National Committee for Quality Assurance, an elected member of the National Academy of Medicine, and in 2009 received the Picker Institute Individual Award for Excellence in the Advancement of Patient-Centered Care. So, without further ado, I'm going to turn to Dr. Bigby.